We are here today to talk about ailments affecting the neck, meaning neck pain and arm pain. This is an area of the spine that has been frequently looked over because most people usually pay attention to back pain and sciatica. So today we'll talk briefly about neck pain and arm pain and go over what some things that one can do to help those issues and what is the cause of some of these maladies. Now, the human spine, or the cervical spine or the neck, is comprised of 7 total bones. And there are discs or cushions that are in between the individual bones of the neck. So, for example, we don't number discs, we label the discs based on where they're at between the bones of the neck. So when someone tells you may have a disc problem at C5-6, that's just one cushion. Now, the reason I focus on the discs is that the majority of the ailments and issues that cause problem for patients are because of arthritic changes about the discs. Now, there are a number of other maladies, disease processes that affect the neck and can lead to arm pain and neck pain. However, we won't necessarily go over those esoteric issues. We'll just discuss the common things. So, with that in mind, patients who have disc herniations or protrusions can develop, in addition to neck pain, arm pain. As I alluded to before, it's similar to a patient who has a disc problem in their low back and suffers from sciatica, or that pain that shoots down the back of the leg. Disc problems in the neck can give you pain that shoots into the upper arm, forearm, into the hand, into the forearm and into the hand. So you can potentially have tingling associated with this as well. The reason this part of the human anatomy or the spine is very important, it's because the spinal cord goes through this part of the human spine. So most of us are familiar with stories of professional football players who unfortunately at times have suffered spinal cord injuries when they've gone in for a tackle or they've been hit in a peculiar way. So the important thing to remember is if an individual has neck pain, and the neck pain is associated with pain that shoots down into the arm, what we call radiculopathy, it's good to bring it to the attention of your primary care doctor if this is not something that does not go away with your regular over-the-counter anti-inflammatories, rest, so on and so forth. When a patient visits us with this type of ailment, we do, as neurosurgeons or spine specialists, we do a physical exam, neurological exam on the patient, and based on the history and the exam, we frequently order x-rays and an MRI. Now, nowadays, majority of the patients are still first seen by their primary care physicians, who are also an excellent resource for management of these maladies. And the important thing is to assure on the exam that in addition to the pain and discomfort that may be radiating into the arm, that the patient doesn't have any other findings. Signs of spinal cord compression can be things like having clumsy hands, especially folks who are a little bit older. They say they have a difficult time buttoning their shirt or putting on their tie. And sometimes they may have an unstable gait. They may kind of be tripping, and they sometimes say it feels as though they're walking on pillows. Now, understandably, as we all age, some of those may be common findings because of arthritis or what have you. However, when it's something that's referable to neck pain associated with these other entities, again, it's very important to bring it to the attention of the primary care doctor. Vast majority of the patients will have small disc bulges, not necessarily protrusions or herniations. Again, in grading the severity of a disc issue, bulges are the mildest form of disc malady, if you will. Protrusions and herniations being the worst. So majority of the patients, after their workup is completed, will be found to have perhaps a small bulge or maybe some mild arthritic changes, and the vast majority are managed conservatively with rest, anti-inflammatories, and once they feel better, physical therapy to strengthen the neck muscles. Now, a smaller subset of patients will need surgery. Those are patients who will have either evidence of spinal cord compression, meaning pressure against the spinal cord, patients who have weakness associated with this disc herniation, and or a number of other issues may also lead a surgeon to recommend surgery. Now, I focused this talk mostly on discs. Some of the other terminology that people may encounter when talking about discs is bone spur, or what we call osteophytes. Bone spurs basically refer to arthritic changes that occur around where the disc space itself is at. So it's not out of the ordinary for someone who is, let's say, in their 50s or 60s or 70s to have bone spurs associated with the disc issues. So sometimes they live together. Now, as far as the surgical approaches for patients who have these kind of issues, if the patient is to the point that they need surgery, as neurosurgeons, we tackle these disc issues either from the front of the neck or from the back. The vast majority of the times we come in from the front of the neck, and we directly tackle the disc or osteophyte or bone spur where it's pressing the spinal cord. We use a microscope. We make a very small incision. Essentially, we've come a long way. These incisions are minimal invasive type incisions. And after we remove whatever disc or bone spur is pressing against the spinal cord, we work our way to the side and also take the pressure off the spinal nerves so that the nerves are being compressed upon. Now, there's a gap there after we've taken the disc out. We usually either put a cage and fill it up with bone and a plate on top to hold everything together. That's called a fusion. The newest and some of the more advanced technology available is called artificial discs or arthroplasties, where you put an artificial disc to preserve motion at those segments. The only thing is some of the artificial disc technology, which is very exciting and newer. When I say newer, it's not new like yesterday. We have about 7, 8, 10-year follow-up on some of these, but we don't have long-term follow-up like 15 to 20 years. So the use of fixation and or arthroplasty will be based on the patient, the pathology at hand, and other circumstances. For example, if there are 2 or 3 discs that you're doing together, usually if it's a 3-level, you can't put 3 contiguous artificial discs next to each other. We have spoken at length about the surgical approach to disc pathologies or maladies in the neck. And we've also spoken about what a primary care physician can prescribe if you visit with your PCP first. That would consist of potentially rest, anti-inflammatories, physical therapy. There are a group of my other colleagues who are in the arena of pain specialty who are also very well versed in the management of individuals who have neck pain and disc issues. Frequently, they will administer steroidal and numbing medication for individuals who have neck pain and arm pain. These are called epidural blocks, and these are administered by pain specialists. Again, the choice of which treatment is needed will be in part made by your primary care physician, by your neurosurgeon, spine specialist, and or your pain specialist. Now, one other subset that I haven't necessarily reviewed are patients who have had traumas. When we talk about traumas, it's not necessarily someone who's in a severe car accident, but it could be someone who's at a place of work who lifts a heavy box, feels a pop in the neck, and suddenly develops neck and arm pain. The treatment for those individuals is also very similar, but it may well be that some of those individuals may need to have more urgent care and present to either an emergency room or urgent care center, especially if they have experienced sudden onset weakness of an arm or hand, or so on and so forth. As we all know, patients who are in significant amount of trauma get brought to the hospital as a level 1 trauma, and they have a very comprehensive workup with x-rays, CT, and MRI. So in the regular workup of patients who have neck issues that have been going on for a period of time, we don't necessarily get CAT scans. CAT scans give us good information about fractures. So that's why patients who are traumas will get this particular study as well. One other specialty that may also be involved in your care and who also provides excellent advice and care are medical neurologists. It may well be that a good number of patients will see, after their primary care physician, a neurologist. And the neurologist, similar to a neurosurgeon, will perform an exam and prescribe the proper medications and or studies. But also know that the neurologists are a specialty that performs a diagnostic study called an EMG nerve conduction test. And that particular study is also, in certain cases, not all, a very useful test to discern whether a patient who specifically has hand tingling has carpal tunnel or are the issues coming from the neck. A good number of patients may have both disc disease in the neck and carpal tunnel syndrome. That's referred to as the quote-unquote the double crush syndrome. So in a very large nutshell, in patients or individuals who have neck and arm pain and or arm or hand weakness, if these symptoms are not going away with the routine measures, we recommend that you see your primary care physician, and ultimately, if needed, we are all very glad to provide care for you, those of our patients with such neck ailments and arm pain, etc. Thank you very much.